Good morning, everyone. Welcome to the next in a series of early intervention innovation funding presentations for NGO projects that the New South Wales Ministry of Health has funded. I'm Fadil Pedic. I'm the Manager of Strategic Research and Evaluation at the Centre for Alcohol and Other Drugs at the New South Wales Ministry of Health. Before I start, I'd like to acknowledge country. I acknowledge the traditional owners of the country where I am working from today, the Gadigal people of the Eora Nation, and recognise their continuing connection to land, culture, and waters. Always was, always will be Aboriginal land. I pay my respects to the elders past, present, and emerging, and to any Aboriginal people joining us for the webinar today. The presentation that we've got today will be running for about 45 minutes. Please feel free to use the Q&A function in Zoom to provide us with any questions. So we should have plenty of time for questions at the end. The Early Intervention Innovation Fund was funded as part of New South Wales Drug Package. It had the purpose of helping build the evidence base for early intervention models and to support people at risk of problematic AOD use. The fund consisted of the NGO Evaluation Grants Scheme and the AOD Innovation Grants Scheme. 14 projects were funded through these schemes, and we look forward to hearing the findings of one of the projects being presented this morning as part of the series. The presentation this morning is a very interesting one. It's entitled Addressing Alcohol and Drug Issues Among Construction Workers, Patterns, Predictors and Outcomes of a Training Intervention. Our presenter today is Professor Ann Roche. The presentation provides details of a multi-site intervention among New South Wales construction workers, examining patterns and predictors of their alcohol and drug use and the efficacy of a training program to reduce risky consumption associated harms. I think you'll find some of the findings around alcohol, cocaine, and pain relief medication quite interesting and potentially alarming. And we'll also make some recommendations for future approaches and interventions in this particular industry. The project was undertaken as a collaborative venture with New South Wales Building Trades Group Drug and Alcohol Committee. So it's my pleasure to introduce Professor Ann Roche. Professor Roche was the director of the National Centre for Education and Training on Addiction, NCETA, at Flinders University from 2000 to 2021, to this year. She has over 40 years experience in public health as a researcher, educator, and policy analyst, and has held academic posts at the University of Sydney, University of Newcastle, Queensland University, and Flinders. Her research goals over the past 30 years have been to improve responses to alcohol, other drug problems through innovative organisational and behaviour change initiatives with a focus on research translation and dissemination. Thanks, Anne. We look forward to the presentation. Thank you.
Great. Thank you so much for that, Fidel. This presentation is a longish presentation with quite a lot of detail on a really interesting study that we undertook in partnership with the Building Trades Group that are based in Rozelle in Sydney. And there's a lot of data that we collected and a lot of important findings from the relationship, the working relationship with this NGO group. So much to share with you. The presentation is broken into essentially 5 parts. So the first part is to give you an overview of the background, the rationale, the partnership, the methodology, the approach that was taken both with the program, the training program itself, and the evaluation. So that's the first part. The next 3 parts are, I've broken down the findings from the 3 results sections. So the initial baseline data at time 1, the first set of data after the intervention, so the time 1, time 2 comparison, and then after 3 months, there's a time 3. So they're the next 3 sections. And the last part of the presentation is to look at what are the key findings, what are some of the things that we've learned in terms of moving forward. So as I say, it is a longish presentation. But first I'd like to also acknowledge the Kaurna people of South, or at least Adelaide, where I'm based at the moment, and to acknowledge past, present and previous and future owners and leaders in the country here, and also to acknowledge that there will be Indigenous lands across the country from where you're based as well, and like to pay our respects to all of those lands. The team that was involved with this project was quite a large team that's shown there. So this project was undertaken in partnership initially between the Building Trades Group and Ken Pidd, where he had a long working relationship, and very much at his instigation. But unfortunately, Ken had to retire quite early due to family issues. Then myself, who ran it as project manager. Jim Finane was our key person in the Building Trades Group, a very, very enthusiastic and passionate person that really helped the success of this project no end. And Brooke Ledner we employed as our Sydney-based RA, who worked very closely with Jim in collecting data. And Janine Chapman, who did the absolute lion's share of the data analysis and writing, supported by Venita Jurasingham. So quite a large team working on this project, together with our partners, as I say, with the Building Trades Group, with whom we've had a long working relationship. And it's of crucial importance that to acknowledge our funders in New South Wales Health, definitely without whom we would not have been able to execute this project at all. So what we did was we undertook an evaluation of this multi-site intervention amongst New South Wales construction workers. So it was originally focused in Sydney, but extended a little bit beyond that as the project progressed. We examined patterns and predictors of alcohol and drug use amongst construction workers, but we particularly are interested in the impact of a training program on knowledge, attitudes, their behaviours in relation to a number of AOD issues, and their awareness of help seeking. And so that's what we're going to cover here today. So for the BTG group in Sydney have been running these training programs for a considerable period of time, and they couch the issues around alcohol and drugs within a framework of impairment awareness, which from a harm reduction perspective is perfect because it removes it from any potential around moralistic or stigmatized judgments about people's personal use and personal behaviours. It's very much part of a context of, are you fit for work? So, and it's not judgmental in any way. So the training they've been doing has been designed to reduce alcohol-related risk to both safety and improve worker wellbeing. So that safety and impairment focus is pivotal to this project. They address issues around policy and procedures and so forth, what things might cause impairment amongst workers. Can you recognise the signs of those things? How does alcohol and drug use impact either impairment or what are the harms, and how do you go about getting help, which particularly for men, we know that can be quite challenging. So the rationale of the work is that an impaired aware workforce is a safer and a more reliable workforce that can provide better peer support. The BTG approach is based on these kind of premises. If you choose to use alcohol and drugs, that's your business. And if you choose to do it in the workplace, well, that's our business. And if you want to stop drinking or using or need other sorts of things, we may be able to help you. So that's the underpinning rationale for it. So some of you would be aware that NCETA has quite a long background and history in workplace-related research and policy development and training and consultation. So Ken and I particularly have worked in this space for a long period of time, and we've done numbers of projects so looking at vulnerable youth, those transitioning from school to work. We've run numbers of comprehensive intervention trials. Again, similar kind of challenges when you're working at the coalface and requiring quite a large multi-skilled team to execute these things. And we've done a lot of consultation with unions in particular and managers and trainers. So the reason that we're interested from a health perspective, particularly around looking at the alcohol and drug use of workers, is that alcohol and drug use is a major risk to injury, illness, death, and general well-being. And it impacts on mental health and suicide, which is elevated amongst construction workers. And it not only impacts workers, but also their colleagues and the community with whom they interact. There are substantial costs associated with alcohol and drug use amongst workers, and these can affect safety and productivity, and it can impact on incidents in the workplace and increase absenteeism and presenteeism. And our most recent estimate, the piece of work we've been doing with NIDRI, where we've looked at alcohol-related costs associated with productivity, it comes in at around $4 billion annually in Australia, and that includes alcohol-related absenteeism. And it certainly contributes to a substantial proportion of injuries and deaths. But for construction, there's been changes also in the legislation that actually requires some on-site training. So this is where this program of work fits into that. It's a legislative requirement now for workers to be at least informed. But also you can ask the question, well, why select construction? And it's because it is a particularly high risk industry. So it is largely very male dominated, has a very large proportion of young workers and apprentices. And as young workers enter the workforce, they often adopt a whole raft of behaviours that are related to the workplace that they're joining. And that may be to do with alcohol and drugs, but it may be to do other things. And as blue collar workers, they're subject to a range of other health related challenges. The working conditions can be particularly challenging. There can be long and irregular hours, and certainly it can be a very demanding environment. And it's also a transient workforce, so there's a lot of movement in and out, and we're seeing quite a bit of pressure on the construction workforce, particularly in New South Wales at the moment with COVID restrictions. So in terms of workplace culture, we know that there's traditionally been high levels of availability around alcohol and drugs, and workplace norms that are often quite conducive to the use of alcohol and drugs and some degree of peer pressure. It's also known to be a stressful working environment, so where there's lots of hazards, job insecurity, and other research shows high degrees of mental health issues and low help seeking. So for all of these reasons, the construction industry is an ideal candidate workforce to look at ways that these issues can be addressed and improved. So all round, these things contribute to elevated risk for alcohol and drug-related harms. So the other thing that we're also interested in is the role of the workplace climate around alcohol and drugs. So the characteristics of the workplace environment and culture, they can certainly be conducive to the use of drugs, or they can discourage drugs. And so the work of Frone from the United States suggests that there are 3 domains in which we need to look at here. What's the availability of alcohol and drugs look like? What are the descriptive norms? Can you describe what you perceive other colleagues and co-workers to be doing? And what are the injunctive norms? Is it perceived by, do you perceive others to think it would be okay? Would they approve or disapprove of your use of alcohol and drugs around work? And these areas have not been researched previously around construction workers. So that's quite an important, unique aspect to this piece of work. That Ken Pitt and I also developed this model about cultural change in the workplace, saying it's not just about the individual workers, it's about a range of factors. The physical environment, there are things there that may drive all sorts of behaviours, including alcohol and drug using behaviour. What kind of workplace controls? We know that where there are fewer levels of supervisions and observation of workers, there's likely to be more problematic behaviours around alcohol and drugs, and external factors and workplace customs. So there's complex things that are at play that contribute to the behaviours of individual workers. There's numbers of ways that workplaces can respond to these things. So certainly the essential components is having a good formal policy, but employee education and awareness has a role. It's part of a larger suite of activities on its own. We would suggest that it's going to be limited, but it needs to be factored in, as does supervisor training and things like EAP supports, and together with other sorts of things that may or may not have a role, such as drug testing or health promotion programs and various sorts of other interventions. But here we're going to focus specifically on how well does an employee education and awareness program work. So the program logic here is that construction workers are at elevated risk of alcohol and drug-related harm. Tailored interventions to address their unique circumstances may be effective, and we want to see if they are. The activities would involve things like workplace health and safety training awareness. So that's the program, the intervention. Then the outputs involve some high degree of negotiation with construction companies and individual work sites to take this on, and the delivery of these 2-hour, each worker is exposed to a 2-hour workplace awareness training session. And then the short, intermediate and long-term outcomes that were sought were increased awareness of risk to health and safety, knowledge about factors that might contribute to risk, increasing their confidence about ability to talk about alcohol and drugs and wellbeing, and knowledge of where to get help, and then confidence in help seeking. So they're short-term outcomes. And then immediate intermediate outcomes were the reduction in risky alcohol consumption and increased referral to services, reduction of workplace factors, and long-term outcomes are their reduced risks to construction workers and reduced related harm in the workplace. So the aims of the program is to raise levels of awareness, increase the workers' commitment to an understanding of alcohol and drug safety, and ensure that everybody, including the safety reps, the union reps, informers, and so forth, get exposed to this training so that they're well skilled up. And some of the unique features of the program is that it was developed by the workers for the workers with consultation from employees and employers. And it used peer education strategies where fellow workers on site get to be involved with the interventions and providing support. And it's certainly well and truly embedded with a harm reduction approach, focusing, as I've mentioned, on safety and impairment. There's also some broader aims that involved this broader inclusive participation. And so the regulatory environment requires them to undertake this kind of training. But the important thing is what they're focusing on is the development of the creation of an environment where conversations on site become really commonplace and acceptable so workers can make informed decisions and then talk about any issues that they might be concerned about. So the intervention elements itself, so what goes into the black box. So the training was provided by BTG's own trainers, and as I said, the program itself was developed by them in consultation with workers. So people wanted to know about some statistics about alcohol and drugs, what are the kind of harms that might derive from alcohol and drug related use, what's the prevalence and the detection rates for illicit drug use, what constitutes drinking responsibly and how long alcohol can stay in your body, those sorts of things. Things about testing, drug testing. Then services, and Foundation House is the service that's provided by the BTG. And so it's been successfully run for a very long time, specifically for construction workers. What does the legislation say in the Safety Act? The program also folded in some important mental health issues, and it addressed some other contributors to impairment, such as fatigue and heat stress, and included issues about how you might manage some of these problems or injury or get treatment. Now, that's an awful lot to cover in a 2-hour session, I have to say. So that's a very ambitious program, but much of it seems to have been very successful and achieved the goals that they were seeking. From our perspective, we set these research questions. Did the training result in changes? This is the primary measure. Any changes to alcohol and drug consumption? And then secondarily, did it increase knowledge about alcohol and drug harm? Did it change our attitudes and beliefs? And did it change awareness of treatment options? And did it change attitudes and confidence in help seeking? To do this, we ran a before and after randomized controlled trial, and we had a total of 719 construction workers participate in the study, 531 in a training group and 188 in a non-training group. So this is a comparison group. It's a non-randomized controlled trial due to the logistics of executing this, which I'll come back to later. The training group were assessed at 3 time points, time 1 just immediately before training, and time 2 just after training, and then 3 months later. And the non-training group was surveyed at 2 time points, times 1 and times 3. And then everybody at each one of these time points completed a hard copy survey on site that took about 10 to 15 minutes to complete. And then statistical analysis for the training group were undertaken at time 1, time 1 and 2, and time 1 and 3. And for the non-training group for time 1 and 3 comparisons. And that's what the design actually looks like there. So on the left-hand side of that, you can see the training group gets assessed at baseline, immediately after training, and then 3 months later. And in that intervening period, we also conducted interviews with some key stakeholders, and the non-training group at T1 at baseline and again at T3. And these were our primary and secondary measures, as I've already mentioned. In terms of the measures that we looked at, age, gender, numbers of years in construction, general health status, we looked at alcohol and drug knowledge, attitudes, perceptions of risk, confidence in recognising signs of heat stress, mental health, fatigue and help seeking. We measured alcohol consumption using Audit C and illicit drug use using some of the household survey data items. We asked questions about alcohol-related absenteeism. We included the K10 for psychological distress and a scale on job stress. And we also measured alcohol climate issues in terms of perceived availability and descriptive and injunctive norms, as mentioned. I'll just skip over the analysis. These are available in the report if you're interested in that. So I'll pause and to see if there might be any questions.
Not at this stage, eh?
Okay, that's fine. So that's part one of the presentation. Part two is, and we have done a lot of work on the sample of 511 is a little bit smaller. We only ran our analysis on the males. In the sample, there is about 4% who are female. And we did that simply so we could relate it back to literature about male workers. So I'll talk through some of our key findings at baseline because it yielded some tremendously important and interesting findings and some things that we hadn't been aware of previously and some findings that are going to be extremely helpful for shaping these kind of interventions into the future. So the average age of our workers was 37, ranging right up to 68 years of age. About half of them had been in construction for quite a period of time, and that's important in terms of exposure to the cultural norms and those working environments. And so if I talk you through some of the key things. So it will be no surprise to find that there was an exceptionally high level of risky drinkers. Throughout these analyses, we also compared these findings to the Australian national workforce of male workforce, and where we were able to, we also compared it to the household survey data for the sample of construction workers to look to see whether our sample was different in any way. Now, the 3 and 4 drinkers being risky drinkers is not exceptional in terms of construction workers generally. It's very, very high, but not exceptional. But what we did find were extremely high rates of cocaine and methamphetamine use, which were 3.5 times higher than the national workforce average. And that's particularly concerning for us, especially the data around cocaine. And the other thing that surprised us was the extent of prescribed painkiller use was 3 times higher than the national average, at least as based on PBS data. And so the cocaine and the painkiller data and the concurrent use of prescribed painkillers, which are likely to be all opioid-based, in conjunction with risky drinking, is a real flag for potential problems. American data show that construction workers are 6 to 7 times more likely than other workers to die from an opioid overdose. And again, it's usually prescribed opioids. So we're quite concerned about that. So if I just give you a bit of a run through in terms of what the data looks like. So if you look at risky drinking here, so the national average, and this is a slightly different definition of risky drinking than I showed before. So the national estimate of people drinking above NHMRC levels, the old NHMRC levels, is around 23%. So this is a heavy drinking group, but particularly amongst the mid-age group, the 45 to 54-year-old workers. Most of our other concerns around illicits tend to cluster around the younger age group. But for alcohol, that's across the board and especially mid-aged workers. Cannabis use, again, higher than the national average. And we compared this to 2016 household survey data. Cannabis use has gone up significantly in the 2019 data. But young construction workers have particularly high levels of cannabis use. They also thought it was very easy to get at work, and in terms of descriptive and injunctive norms, they were very high. So they knew people using, and that they thought their closest mates wouldn't disapprove. Methamphetamine, similarly, much higher than the national workforce average. And again, that's concentrated in young workers. Easy to use methamphetamine at work. Good 10% knew someone who used. Injunctive norms were pretty positive around that as well. Cocaine use When the national average for workers is around 4%, it was 23% for this sample. So this was extraordinarily high and very much a surprise to us. It was high across the board, but again, very much concentrated in those workers in their 20s and early 30s. So very easy to use at work. People knew others who were using, thought that mates would not disapprove of use. And then the other one, which really again surprised us very much, was the level of prescribed painkiller use. And again, very high across the board. Now, we would expect to see high levels of painkiller use in the mid to older age workers, simply because of the level of chronic pain and injury that you might expect amongst the older worker. But it was also concerning to see such a high level of use of painkillers amongst young workers. So now we also then look to see, okay, amongst the risky users, who were using cocaine and who were using prescribed painkillers. That concurrent use here of amongst the mid-age group of prescribed painkillers amongst risky drinkers is a real flag for potential overdose and another range of harms. So important things that we've identified there. So in terms of comparing this sample to, say, the national estimates, the things that really stood out for us were cocaine and prescribed painkiller use, and that high level of use of prescribed painkillers in the mid-age group, on top of what we already know about the young worker. There was a series of questions that we asked about their perceptions of risk. We asked about perception of risk across the range of 5 or 6 substances, the night before work, immediately before work, during work. And if we look here just at risk from coming to work, nobody thought there was much of a risk if you took painkillers immediately before coming to work, even though those substances are likely to be opioid-based. And then you see a higher perception of risk for alcohol, for cannabis, for cocaine, for methamphetamine. And to some extent, we would argue that the perception of risk probably reflects the level of social media and health promotion campaigns and campaigns that are run around methamphetamine. And so that's helpful. And we think that this is a good thing, that there's this perceived high level of risk. But I'll come back to a social desirability potential bias when I look at the limitations. And of course, perception of risk is lowest amongst the young worker group and the higher using groups. So there's still an important distortion there. We asked about alcohol-affected days off work, so in terms of absenteeism, 1 in 10 workers reported being absent due to alcohol and drugs in the last few months. Now that compares to around 3 to 4% for the general workforce, so very high levels of alcohol-related, drug-related absenteeism. And in terms of presenteeism, about a quarter reported attending work with a hangover, and other work we've looked at suggests that for the general workforce, that might be around 11%. So presenteeism a little bit harder to assess. In some of our other analysis we did on the baseline data, we looked at some of the predictors of alcohol and drug use. So across all drug types, being a higher consumer of alcohol was consistently associated as a predictor of illicit drug use, as was poor general health and younger age is predictive of certainly cannabis and cocaine use. Now, higher psychological distress is really interesting because it's known to be a contributor to suicide amongst construction workers, but it was only associated with cannabis use. And some of the more recent work that we've done for the 2019 household survey data starts to show that that association with psychological distress as a predictor of cannabis use has dropped off as cannabis use has become increasingly normalised. And so it's important here, if you think in terms of how do you tailor and shape your interventions, if you think it's predicated on the basis that people are using because they're trying to self-medicate, then you'll tailor your intervention in a particular way. But most of this drug use is not about managing psychological distress or job stress for that reason, for that matter as well. So these still are very important issues, but people are using often for pro-social reasons, not to manage their own psychological distress. And as I've mentioned, perception of availability extremely high, and the descriptive and injunctive norms also very high. Help seeking was another additional component to the analysis that we ran. So psychological distress is higher than the national average in this work group, particularly in the younger workers. Psychological distress tends to drop off as you get older. And there was generally high levels of reluctance to seek help. And again, this is very valuable information. Psychological distress was negatively predicted in the likelihood of seeking help. So the higher your psychological distress, the less likely you are to seek help, which is, again, stresses the importance of encouraging young workers and giving them the skills to seek help if they need it. And we know that that relationship gets mediated if you know how to actually get help and if you increase confidence in talking to your mates about these things. And so again, it highlights the importance of folding in some of the mental health issues around concerning male construction workers, as well as their alcohol and drug use. And it also gives us a bit of an insight about how some of the intervention aspects might deal with reducing stigma and enhancing confidence. Crucially important. So I'm halfway through the first, so I'm on track. So the key messages from our baseline data alone: cocaine exceptionally high and much higher than we expected to find, much greater prevalence than cannabis. So we've been giving so much emphasis to cannabis and to methamphetamine, which have tended to not have cocaine on our radar. And there's some very important reasons why we should. And similarly, very, very high levels of prescribed painkiller use. And our concern here is that they're often seen as innocuous substances with not necessarily high levels of problems associated with them. In terms of which workers to be focusing on, certainly most alcohol and drug use problems are concentrated in the younger workers who are less likely to recognise risk, but also the 45 to 55-year-olds, the heaviest binge drinkers and the heaviest users of prescribed painkillers. So again, making sure that the interventions cover the wide and appropriate age ranges to deal with this diverse set of issues here. And in terms of the sorts of supports or interventions required, certainly targeting, as I say, young workers and mid-age workers, increasing the focus on specific health and safety risks that are associated with both the use of cocaine and painkillers, but used in conjunction, in combination. Many people do not understand that there's a synergistic effect when you use a substance such as alcohol and an opioid painkiller that are both central nervous system depressants. So this is really informative alone before we move on to the next stage about, well, what did the intervention tell us? So we've learned an enormous amount about construction workers in New South Wales that can inform many other interventions into the future. Some of this has been written up and published, so you can see the publications at the end. So as I move to the third part of the presentation, the question then is, okay, having given them a 2-hour intervention, did that work? What did that achieve? And I've always been pretty cautious about attributing potential for much success with limited 2-hour one-off sessions. But in this instance, there were statistically significant post-training effects that were found for the vast majority of the secondary measures. So increases in alcohol and drug-related knowledge, awareness of harms, increased confidence in recognising signs of impairment and ways to manage fatigue, increased perceptions of risk to health and workplace safety, improved awareness and confidence in accessing support, and increased confidence in the ability to talk with co-workers about alcohol and drug issues, and self-reported increased likelihood of actually seeking help, suggesting that the training was successful in stimulating conversations and reducing perceptions of stigma. And these things alone, I think, are gold and incredibly important. So that part is a big tick for the program. It achieved many of the essential goals that had been established immediately after the training. So the issue then about the changing perceptions of risk, so that there certainly was, even though there was some degree of a potential ceiling effect because the self-report levels of perceived risk were pretty high, except for younger workers. But we saw an increase in an understanding of risk to health and safety from alcohol and drug use. And most of that came from understanding that consumption the night before could increase risk at the workplace the following day, particularly if you're drinking more heavily or if you're using cannabis. But there was this ceiling effect. And again, I'll come back to it in the limitations. And the other one that was important, you'll recall, perception of risk around painkillers was the lowest of any perceived risk, and that increased significantly. So again, we're really pleased about that particular outcome as well. The other important question for this sort of work is, well, how acceptable is it to the training participants, and do they find it useful? And they definitely did. So the vast majority of responses about, was it useful or very useful? Absolutely, people thought it was useful. And certainly the subjective feedback from the key stakeholders reinforces this message as well. So that's the third part. So for T1 to T2 was achieved very successful outcomes and hit the nail on the head in the vast majority of areas that were wanting to be covered by the intervention. But then the really important thing is, well, when we compared T1 to T3, so this is the difference between what happened at baseline and 3 months later. And this then starts to combine both the training group and the non-training group. So just initially for the training group alone, the achieved increases in knowledge and confidence and knowing how to get help, those improvements were sustained at 3 months, which is very important, and their confidence in recognising heat stress and managing fatigue and so forth. So again, we're pleased about that. That's another good result. The training group were asked at 3 months, since the training, do you think more carefully about factors that may impair your health? And certainly the vast majority of them said yes, they do. And so that suggests that there should be some ongoing impact of the training in terms of changing perceptions around managing safety issues and health related issues and impairment. So again, a good result. But not probably unexpectedly, there was no significant improvement for the primary outcome or illicit drug use measures. Did a 2-hour training education session make a difference to your use of risky levels of alcohol or illicits? And the answer is pretty much no, it did not. But I think that's an ambitious goal. There was a difference, there was an improvement if you look at the proportion of workers as categorised as risky drinkers in the training group compared to the non-training group. So that there was a small decrease in the training group and a slight increase in the non-training group, which was sufficient to give a statistically significant increase between the two groups. But it's a bit of a quibble. There really is not much of a difference in terms of behaviour change if you just look at the training group scores on Audit C. And similarly, we saw no significant change in terms of any of the illicit drug use over time. So this is worthwhile bearing in mind. And again, it's informative. If you're really wanting to achieve behaviour change, you're going to need substantially more and a range of different strategies than just a 2-hour education session. That's not to say that the 2-hour education session is not valuable, because it clearly is extremely valuable. It's just getting to this end will require more concerted effort. We also then asked the question about, did it impact absenteeism? And this looked like it was trending in the right direction, with the training group showing a small improvement in reported alcohol and drug-related absenteeism and a small improvement in help seeking, but these were not statistically significant. So again, it suggests that what you need is some further input along these lines and a raft of complementary strategies to achieve this. So at T3, 3 months down the track, we've sustained the positive achievements from initially from the training. The workers are reporting that they're thinking more about the impact of these sorts of things, but we're not seeing specific behaviour changes, which is probably no great surprise. In terms of the stakeholder feedback, where we had run a number of interviews, the stakeholder feedback was really positive. It highlighted the importance of opening dialogue. So what they were saying was that you were seeing people having much more comfortable conversations about their alcohol and drug-related patterns of use, or where it might have a knockover effect in terms of safety and impairment at the workplace. So that was certainly reducing the stigma around these things and the associated potential mental health issues, and a greater degree of comfort about at least exploring the issue about talking about problems and seeking help. So stakeholders were very much of the view that there were very much positive benefits, and they were able to see it in a tangible way, literally at the coalface, as it were, at work sites. So in this last part of the presentation, if I turn to the issue about what are some of the limitations, the data suggests that there probably is a social desirability response bias going. So if we compare the responses for the non-training group, there were significant differences on 16 out of the 37 outcome measures. And so the non-training group reported higher alcohol and drug use. Now that's concerning because the training group already had very, very high levels of use, lower perceptions of use, which kind of suggests that the training group were over-egging, overcooking what they were saying in terms of their perception of risk. But again, a very important finding. And they had lower confidence than the training group. Again, so it suggests that the training group was saying, yeah, I'm reasonably confident. So this is helpful to inform what future programs might do. And without the benefit of running research where there is a comparison group, you wouldn't get a good sense of what that social desirability response bias might look like. So this is highly informative. Similarly, we had a very high dropout rate, unfortunately. The logistics of executing these studies are very, very challenging, and huge kudos to both Brooke and Jim with this massive amount of work they did on the ground. But there was a difference between the people who dropped out at T3. They were more likely to have used methamphetamine and more likely to have lower perceptions of risk and have greater confidence, lower confidence in recognising signs of fatigue and so forth. So again, helpful and informative on many fronts. So my last couple, 3 or 4 slides here is, okay, what are our key, in summing up, what did we learn from all of this? So risky alcohol use remains high, which we've kind of known. So there were no new findings there. But when we analysed it, it's highly predictive of other drug use. So tackling risky alcohol use probably still is our #1 focus for a variety of reasons and across the age range of workers. As mentioned, cocaine use was the sleeper drug for us, exceptionally high and much greater prevalence than cannabis. And so our understanding and dealing with cannabis now is changing so rapidly, given its altered legalised status. And this high level of prescribed painkillers and very low perceptions of risk associated with it. So very important learnings there. Which workers? So most problems associated were in younger workers, as we know, but also we need to focus on these mid-age workers, not just young workers. And we need to spread our range of supports to focus on the use of cocaine and painkillers, giving greater emphasis previously, and using some multi-level responses involving education, but culture change. And so that's one of the big takeaway messages back to the people devising the training and wanting to complement training with other things. Focus on what things can be done to change workplace cultures. So what worked? The subjective and qualitative feedback was very positive. The training program was very well received and widely accepted, and the training experience was reported to have resulted in certainly increased openness to talking about alcohol and drugs, reduced stigma, which we think is a fantastic result, and some degree of observations about positive translation of training objectives to the work sites. And so clearly it's the work is supported and needed, even if the evaluation is logistically extremely challenging. And so my last 2 slides then. So what would you do differently in future training? Well, you need to tailor some of those training approaches to reflect those changing patterns of use and patterns of use that hadn't been recognised previously and the associated problems. Adding in some additional content, so related to opioid dependence and potential overdose risk. And it was also suggested that incorporating some lived experience might carry some considerable credibility in altering what the program looked like. So that's an interesting one for discussion. The need for regular refresher courses was hugely important in a way to reinforce some of the key messages. So you have to be quite realistic in terms of what a 2-hour intervention can do. What else can you run? What else can you offer to complement that is now the key question. They were also, some of the workers were asking for more practical guidance on lifestyle change. So, okay, you're giving me this advice about, well, if you do X, Y, and Z, this can create these kind of harms and workplace impairments. Let's talk practically about how you can change your lifestyle appropriately. So very helpful. And so the final take-home message then for this program was work is that the evaluation yielded some fantastic and important findings that really has added a lot of value to very limited evidence that can be used now to inform much more effective approaches to addressing alcohol and drug-related harm in the workplace. The partnership was absolutely essential. We as researchers could not have appropriately designed this kind of intervention or executed it. So working hand in glove with our partners was absolutely brilliant. Again, I stress this issue about needing to be realistic about the expectations that can be achieved in a 2-hour session. We need to think about more intensive, nuanced approaches that complement this kind of educational approach. But for me, it's quite interesting that I think it's restored my confidence in the value of running educational programs. But still, I would argue that the overarching aim has got to be about workplace culture change and looking for that multitude of strategies that can bring about that bigger picture change. And again, emphasising again the challenges of conducting this kind of research in this kind of work environment where it's highly dynamic. They're very transient and really time pressured. So getting a foot in the door to actually collect data is very, very difficult. And it's more costly to do that because of this. And into the future, obviously, as a researcher, I'd say, yes, we need more resource intensive, larger scale projects. And that's both in terms of the intervention and in terms of the evaluation. If we had a fully randomized trial, we would be able to come out with much more definitive findings at the end of the day to complement the very valuable and useful information that we've collected so far from this fabulous project. And that brings us to the very end of this presentation. And as I say, there's a set of peer-reviewed publications that came from the baseline data, and there's a detailed report that I believe is probably available to you from New South Wales Health. And there's on the NCETA website, we have a compilation of resources for workplaces, including our work life site, which contains the most comprehensive array of information and tools that you might like to gather in Australia, if not globally, and a range of publications. And certainly if you wanted to find out more about the intervention, it's worthwhile contacting the BTG group in Sydney. So thank you. I'm happy to take any questions or discuss any aspects of the project.
That's fantastic, Anne. Thank you so much. Very impressed you were able to present that within the time frame. Very, very comprehensive study. Obviously quite a few elements of the project involved as well. To compound things further along this bug that we seem to have in Zoom, my camera has now died. I've tried both cameras and my second camera has now died. We do have a question from Joe Ross. Given the transient nature of the construction workforce, how can higher levels of workplace AOD health and safety awareness training be maintained? And is there any drug testing done by the construction industry?
Right, your volume level for me is a little bit low, but I think the question was, is any drug testing done?
Yes, that's correct.
Yeah, there is a degree of drug testing that is done. So absolutely. But it's quite interesting in numbers of discussions that we've had with some of the really big blue-collar industry groups. Many of them are rethinking the amount of resources they've put into drug testing for numbers of reasons. They're not getting positive results the way that they had been previously. It's a very costly program. They worry about some of the inadvertent and unintended consequences. Anecdotal reports suggest in some instances people might move away from using potentially less harmful substances such as cannabis and take up more harmful substances such as methamphetamine to avoid detection. So there's a raft of reasons why many groups are starting to rethink how they use drug testing. So it's not to say it doesn't have a role, it does, but it's certainly not the be all and end all that some of the drug testing commercial companies might have suggested that it was. And it certainly is used in construction to some extent, absolutely.
Terrific. Thanks very much, Anne. You touched on the social desirability element and the implications for training, for the training group and for future training, I suppose. What do you think it means then, given the social desirability element, in conducting our surveys and evaluating programs? Are there any ways around that?
I think as people become, as workers become more familiar with these kind of programs, and one of the important outcomes was that they became more comfortable, more relaxed, and probably less defensive about talking about those things. That will help overcome social desirability biases, where they feel that they need to either underreport their alcohol and drug use, increasing anonymity in the and reassuring people that the information that they're giving is highly anonymous. And so there was skepticism about that. So if you can do that, we had to use pen and paper based forms. And I think if you could do it if you could do the data collection online, that increases your confidence in anonymity. There's numbers of studies that show that increases your confidence in anonymity. Once your confidence in anonymity is increased, your probability of giving much more honest answers increases as well. There's really interesting data on people will tell you much more if you do it online. So that will overcome that social desirability response bias. The one about perceptions of risk and their confidence levels, I think just in time, as these things become more common, people will feel they don't need to kind of fudge that stuff so much.
That's fascinating. So we should be expecting much more reliable and better data from the census this year then?
Yes, that's exactly right. Yes.
That's great. The other question I was interested in is you suggested that perhaps adding elements of lived experience to the training would be powerful as well. I suppose by that you mean having people who worked in the industry or are working in the industry and who've experienced harm and have gone through programs or experienced some change in behaviour?
Yes, so this came up in a number of the discussions and numbers of the stakeholder feedback. And the evidence around how you might use people with lived experience is still fairly mixed, and I think it needs to be thought through very carefully. That I think what they were seeking was that a whole issue about, well, how do we give people better tools to make lifestyle adjustments? And rather than using what I've seen in numbers of sessions, really sensationalized presentations where people talk about extreme addiction with, say, methamphetamine and the dreadful things that happen to them, which is kind of outside the experience of probably most people. It may not be that kind of lived experience. It might be much more people who had less problematic levels of use, but still enough for it to be concerning. And so people can identify much more closely with it and say, yeah, I tend to drink like that, or have used drugs like that and hadn't realized these were the potential consequences, without going to the extreme end of the continuum where you have people who have whose lives have become, have absolutely unraveled, and then they've gone through major rehabilitation, etc. So they're so far to the extreme, many people don't identify with them. And I've sat in sessions where people I've listened to them walking out sort of saying, yeah, well, that would never happen to me. So having something with lived experience, which is closer to the the experience of the majority of workers and how people have learnt to manage and reduce harm and reduce impairment from a harm reduction perspective might be an alternative way to go. But I think it needs to be thought through carefully.
Sure. I think you were saying, obviously, due to the constraints around loss to follow-up, many of the conclusions around changes between T1 and T3 were difficult to draw. Was there any anecdotal information or feedback from employers or stakeholders about changes in behaviour they might have noticed in the workplace, or changes in attitudes?
Yes, the feedback from particularly the supervisors were things like it was much easier for supervisors to have conversations with workers about issues that might be representing a safety risk that was related to, say, alcohol and drug use, so that they had a basis then to sort of to build the conversation on. So they found that very useful. The issue about help seeking and legitimising and sort of normalising help seeking was something that they observed, and encouraging workers to be able to talk to each other about mental health issues, because that was folded into it, and normalising that. So yes, supervisors and managers were saying that it basically, it kind of just gave permission for people to talk about these things, and it made it just more part of a kind of day-to-day conversation that you might have, and they considered that to be invaluable.
So placed the issue on the table and made it more acceptable as a discussion, point of discussion.
Yes.
We don't have any other questions on the Q&A, but from a methods standpoint, that loss to follow up, 73% loss. I mean, is that typical of other work that you've done in other industries, or is that higher than you'd expect?
That's higher than we had expected, but the work settings were also substantially more transient, and transient in the sense that they were moving from one job to another, and so keeping track of where people were. So it's a particular challenge for the construction industry. So for instance, where we've run trials in other workplace settings such as manufacturing, those workers tend to stay pretty much in that place, and that's true for many workers. So it's a unique aspect to numbers of working environments, but construction particularly, where you might work on one job for a couple of weeks or months and then you're off somewhere else, and you may not be with the same team. So we're trying to track groups of individuals as well as who this group had been exposed to this training at that point in time. So we want that group. So there's two sets of issues with this. So, and I don't know, electronic tracking and electronic data collection and the use of electronic media will make it a bit easier into the future, I think, but it needs to be factored into the study design much more carefully.
Fantastic, thanks, Anne. Yeah, I can see it's a industry that's obviously more with some greater transience than some other industries you might be working with. Well, really pleasing that despite those challenges, Anne, you've completed the project, and there's four publications already out and 3 planned publications, and I think actually 3 conferences and presentations that have come out of this work. So it's very pleasing that it's being disseminated, including today, and I want to thank you for your time today. Much appreciated, and for people online, I hope they appreciated the depth of this project and the many wide-ranging implications that it's delivering for that particular industry and for training in particular.
Thank you so much. It's been a pleasure. So
thanks, Anne. All the best. Take care.
Bye-bye now.
Everyone.
Bye.
Bye-bye.